right the first time. No. Let's see what we have here. Hi. All right. So I am. I got this. I got this. I wasn't sure, and it was locking up on me a minute ago. So, oh well. I'm here. I'm live. A little late, but that's okay. I'll be with y'all for a little bit. I wanted to talk about a few things, but one of the things that I want to talk about was the diagnosis code selections because what so what happens is I've been seeing a lot of missteps lately with some of these diagnosis code selections. So I wanted to talk about some things to kind of help new students. I know it's a lot, especially like when you're working in your first job and you're trying to figure out everything. You don't want to miss anything as far as like missing picking up something like that you should have picked up. But some of these rules that I'm going to talk about today are just some things to kind of keep in mind when you're thinking about what diagnoses to select. So sometimes a patient is coming in with lots of diagnosis, and when that happens, you need to look at what the provider is, what they're treating, what is relevant to their encounter with that provider, and does that diagnosis that the patient has, does it have an impact on the plan of care? Does it have any impact on what the provider is doing? Do they have to change their approach because, for example, the patient is diabetic and they can't give them certain medications because otherwise it's going to cause their blood sugar to spike? So they have to use a different medication. Well, when you have to use a different medication, insurance is kind of like, hey, this one's more expensive. Why are you using a more expensive medication? Well, if the doctor says in there in their documentation, well, this patient is a diabetic. The current review of the blood sugar logs or the labs online in the system have shown that the patient is stable. Patient was counseled on a potential spike in blood sugar, but that to monitor their symptoms and monitor how they're feeling. And so we're going to go ahead and use this medication. So that is going to ensure that the provider has a less chance of being denied because they said that this diagnosis was relevant to their plan of care. Now, the provider may tell you, hey, um, I, I'm not this patient's primary care provider. Why do I need to document that? And to whereas I would tell that provider, but you do have to consider that diagnosis when you are planning their care, correct? Yes. So even though you are not their primary care doctor, it is still part of your plan. We still have to collect this information. Not every diagnosis that we select is going to be a diagnosis that that provider is treating. We just need to know what is the relevance to this diagnosis in relation to the diagnosis that is the diagnoses codes that are being selected, okay, and its impact on what is driving that visit, right? So I know I jumped in a little bit, but that is what I do. I don't plan these things. It just comes out of me, you know. So I hope you're taking notes. If not, it's okay. I leave my live shows up. I did name this specifically for this one, Diagnosis Coding Selections FAQ. So if you want to refer back to it, you can go through my videos and you'll see it. Just Diagnosis Coding Selections FAQ, and so that way you can do that. I was gonna do this on a separate video, but uh, my evening ran a little bit late tonight, so I was like, you know what? I had a video filmed, um, but I didn't get it uploaded. Do have it uploaded, but I didn't do like the thumbnail and all that good stuff. So I said, you know what? I have not seen and talked to my audience in quite some time. I was out all last week recovering, and I am doing fine now. So I just wanted to come on and relieve the people that I am back and that I am going to be back on my show schedule. I will upload the, since this computer wants to be slow, I'm going to go with this one. I just need to know what the comments are saying because I see them whizzing on by and I can't read them because my other computer here is going slow. All right. Hi, Joshua. I'm doing great now. Thank you. Who is this? Stephanie. Hi, Stephanie. Hi, Creative. Yes, I am. I am feeling better. Thank you. And I did what I needed to do to feel better, and here I am with all of you. Couple things before I really get into the meat of the potato of this video, which is about diagnosis coding selections. So if you are a new coder, even if you are an established coder, maybe getting cross-trained into a different specialty, and you're thinking, oh my gosh, what do I pick up? Because that is the big thing, right? What do I pick up? And you don't want to pick up too much because then it looks like you're just trying to code anything that sticks. We need to code what is relevant, okay? The other thing that I wanted to say is this week is study hall. So if you are on my Patreon channel, if you're one of the paid subscribers, because Patreon allows people to join for free, which I don't post free content on Patreon. The only thing that I post on Patreon that everybody can see is like announcements, right? If there's a schedule change or something. Occasionally I'll post something exciting or whatever, but I don't really post free content on Patreon. So, Patreon for my paid subscribers this week is going to be study hall. So on Thursday, the 12th, because I put it on there as mistakenly, I put it at March 9th. I don't know what I was thinking. March 12th will be study hall. So if you are one of my paid subscribers, and it's like the minimum pledge right now is $25 per month, you get access to the study hall, which is about an hour. It can go over if I so choose. If the conversation is exciting and everybody's got questions, I'll go over an hour. But it's an hour, and we meet live over Zoom. It is just us, talking, and I have my books out. You can ask me coding questions. You can ask me career questions. Everybody gets a turn to ask a question at least, and then we rotate until we run out of time. And then when we run out of time, then we close the meeting. But you get access to that meeting, and like I said, it's $25 per month. You don't have to sign up for longer than a month if you don't want to, but your pledge will also get you access to the hundreds of worksheets that I have for coding practices, and I give the answer keys and of course the quiz. And then it's not just about coding, it's about medical terminology, anatomy, pathophysiology, about bunches and bunches of them, okay? I should take the time to get them organized. But one thing at a time, one priority at a time. So, but that's all available there for my Patreons. And if you're interested, you have until Thursday. The study hall starts at 5 o'clock Pacific Standard Time, 7 p.m. Central Standard Time, 8 p.m. Eastern Standard Time. So if you sign up before then, you will have access. I post the link for the Zoom meeting in the community tab of Patreon. And usually my Patrons will get an email talking about what I posted, so it goes right to your inbox. If not, you can check the community tab before the meeting time and join us. You know, you do not have to ask a question. You do not even have to turn your camera on. But this is a time for you to ask questions if you do have questions. And the thing about study halls, I will say this: the thing about study halls, if the people are not paying for a study hall, there are people who are less likely to participate, right? Because it's not just me who runs study halls. I've heard from other people, other health information educators who have tried to do study halls for free. And then they say that people just don't ask questions, they don't participate, or they're too scared, they don't want to speak up. Study halls are for your benefit. The whole mishigas of, oh, I don't want to feel stupid, this is the wrong field for you. If you think that you don't want to ask anything because you don't want to look stupid, that is the dumbest reason not to ask a question. Now, I say this with a caveat. If you are asking a question that has already been answered several times, then yes, I'm going to look at you. But if you are asking a question that you say, Blue, I know you said this, but what about this in relation to my question? Okay, now we have a different facet of this. And this could be like, hey, Blue, I want to work in the outpatient setting. Is home health outpatient as well? Yes, and we could talk about that. That makes sense, right? But if you're saying, oh, Blue, what books do I need if I want to take the CCS exam? I'm going to look at you. Why? Because that is a simple lookup on the AHIMA website. Don't ask me what books you need to take the CCS exam. You know you want to take the CCS exam? You should already know what books that you need. Now, you may not know the publishers, right? That are like all the publishers or whatever, like I do, right? But I do this all the time. But what you can do is go to the AHIMA website and it'll say there's a specific link for recommended books or approved book list. And then you can check there and it'll tell you all the ISBN numbers, every single publisher that's acceptable. And I've said this 200 million times on my channel. I love Optum, Optum Coding Books, Optum ICD-10 CM Expert for Physicians. Of course, we all have to have the AMA CPT Professional Edition, the ICD-10 PCS Expert Spiral Bound from Optum, the HCPCS Expert Spiral Bound from Optum. So those are the 4 that I recommend. They are all approved. If you are taking various exams with AHIMA or with AAPC, they are all on the approved list of approved books. So if you're not paying attention to that, I'm just saying, okay, guys, we need to use common sense there. And I don't hand feed, I don't spoon feed. I'm very direct. People call this being rude. I don't care because it's not being rude. And I know it's not being rude. It is the fact that you are coming into this industry from wherever you're coming from. And there are going to be people that you're going to be working with who will be the smartest people that you have ever met in your whole entire life. And they have the patience that much. They do not have patience. And if they do have patience with you, that patience is going to be short-lived if you are not asking questions that have substance. So learn to have questions that have substance. And I know this is difficult, especially for my young people, because we're all learning from iPads now, right? And we're all learning from the computer. It's very hard. Y'all didn't have critical thinking exercises like we did in my generation. I'm Gen X, right? And Gen X and above, we all had critical thinking questions. Millennials, y'all caught the tail end of those critical thinking questions. But that's something that, we all need to work on. We have a personal responsibility to work on that, right? And, be offended, don't be offended, but it's not meant to offend you. It's meant to prepare you, okay? And just like I would want anybody else to be prepared coming into this so that it's not such a shock to you, because it's such an investment. It's an investment of time and money and hours and tears and sweat and all of these things, because you're trying to learn medical billing and coding. So you need to bring your A game and bring it in fast. Because again, asking me simple questions like, what books do I need for the CCS? Well, you knew you want to take the CCS. You need to look online. I don't have to answer this question. Okay. So with that said, all the little announcements are done now. So let's get to how do we know what diagnoses to pick up? We do not have to pick up all of the diagnoses that we see on this record, depending. Now, there are some rules with some facilities. Some facilities will say if the patient uses tobacco, you got to pick up the tobacco use code, or you got to pick up whatever they do, like with cigarettes or vape or whatever. You got to pick that code up. And they do that sometimes for statistics. And so if you see something like that, then yes, you got to pick up. If you're working and the patient is a soldier or was a soldier, they have a history of deployment, military deployment, then that's something that there's a statistical thing that, okay, let's capture this code. So there's different things that they're going to use for some of this information. So always make sure that you look at your hospital or your department's SOP, standard operating procedure, to see if there's anything, any little quirky thing like that that you got to pick up. And always keep that in mind, because you have to look at what they want, because sometimes they'll want you to pick up those things. And even though the provider didn't have any relevance to the visit, it's a data collection for the facility or for the hospital. So always make sure that you pay attention to that. But for the interest of being accurate in what we are picking up, first we need to ask ourselves what brought the patient in, or what bought the bed, right? Why did they come in? And if what they came in for was, for example, a cough, let's say they presented to the ER and they said, okay, we did an x-ray, we did all kinds of scans, and we think that there's something going on, so we're going to admit this patient. The patient is admitted to the inpatient side of the house, right? And the provider is going up to go visit the patient. Let's say the pulmonologist is going up to the floor to go visit the patient. They were admitted by the internal medicine team, and they said, okay, we need to bring in this specialist, this pulmonologist, to see what's going on. Patient turns out that they have pneumonia, okay? So they do their testing, they take their samples and everything, and the patient has bacterial pneumonia. And they're waiting on the results from the pathology to find out what the offending organism is, right? But we know the patient has bacterial pneumonia, right? And I'm just saying this for illustration purposes, okay? So the patient came in with a cough. They were admitted with a cough, but their final diagnosis was pneumonia, bacterial pneumonia. Are you going to pick up cough? No. For that final diagnosis, no, you are not. Why? Because coughing is a symptom of pneumonia. And so that's something you got to keep in mind too. Is this a symptom? Even though they came in with it, is this a symptom when we have a final diagnosis? And if it is, we select on that outpatient side, we are going to select that final diagnosis. Now, of course, I talked about the patient being admitted. So I should have prefaced this with, when a patient is admitted, and this is a professional fee visit. So you'll often see job listings for pro fee coder, PRO, and then FEE, or they'll call them professional fee coders. And so what happens, the simplest way I can explain it is the patient is admitted to the hospital by whatever service, internal medicine in this case. Internal medicine looks over the patient and says, you know what, we need to bring in a pulmonologist because they have a respiratory problem. So they call up pulmonary and they say, hey, we got a patient that was admitted, and we find some things that are concerning. Can you come and check this patient out? Pulmonologist says, sure. Pulmonologist goes, leaves their clinic, goes up to the floor and checks out the patient. Now this pulmonologist needs to be paid for their professional fee service, okay? So you'll see those types of codes in the evaluation and management section, initial hospital stay, and then it'll say subsequent hospital, and then it'll say discharge from the hospital, okay? So you can look at your evaluation and management section and you can see those codes there. So that way, okay, I know initial hospital stay, subsequent, and then discharge date. So you need to look at like all the requirements for that. But when the patient is coming in and that pulmonologist sees that patient and they said, okay, they have a cough, and then the pulmonologist says, oh, you know what, this is pneumonia. And then they find out it's bacterial pneumonia, then that's what the coder is going to pick up, is that bacterial pneumonia. They're not going to pick up a cough because that's a symptom of the um, of the pneumonia. How do we know what a symptom is versus it's just we don't know if it's connected or not? You have to look at the documentation. Sometimes they'll say the patient has chest pain, but they also have cardiovascular disease, right? Now, technically, it could be a symptom of the cardiovascular disease. Of course, that's when there's thickening of, plaque on the walls and everything like that. And so it could cause chest pain. But let's just say that the doctor says the patient has chest pain that is not a cardiac related. So maybe it has to do with their rib cage, or maybe it has to do with something else. So in that case, yes, we would pick up chest pain according to whatever they selected. And then we would also code the cardiovascular disease if that's relevant. Okay. But in that case, even though it looks like that could be a symptom, the doctor specifically said that this is not related to the cardiovascular disease because it's not cardiac related. So we're going to go ahead and pick up this chest pain. Now, if they're coming in and they have chest pain and they're about to have a heart attack, obviously we would not pick up chest pain. We would pick up the heart attack, right? Because that is showing that that's a symptom of the pending heart attack or the heart attack. So we have to learn what our symptoms are. So that's one of our first stops, okay, is learning that. Then we have to see what all impacted the provider's decision making. Like I said in the example of the orthopedic doctor or PA or surgeon who is seeing a patient and going to give them a shot and for pain in their knees because they have osteoarthritis of the knees, but the patient is a diabetic. I always use this as a really good example because there's such a clear difference and there's such a clear need for this information to be collected. Why? Because if a orthopedic clinic is using the slower acting medicine to take care of these diabetic patients. Say, for instance, there's a lot of diabetic patients that go to this particular orthopedic office, and there's a huge spike. No, uh, no pun intended, spike, right? But there's a huge spike in using medicine that's more expensive because it's more beneficial to the patients because it's not going to spike their blood sugar. What is the deal here? So all the insurance has to do is run that report and they'll see, oh, they're seeing a lot of diabetic patients here. Okay, we'll cut them some slack. That's going to save that doctor's office from a lot of denials, right? Because they have a specific reason why they're selecting this more expensive medication. So that's something you're protecting the providers, you're protecting the revenue, you're protecting the patients because there's not going to be any denials because there's a clear cut need. Okay, so would we pick up the diabetes if the provider says, well, the patient's here for osteoarthritis of the knees, they are also a diabetic, and their blood sugars are stable. We're going to go ahead and give them a shot for their pain. Yes, we are going to pick up the diabetes. But which diagnosis would go first in the scenario of the patient coming in for osteoarthritis of the knees and they just happen to have diabetes? Well, what bought the bed? Why did they come in? They came in for the osteoarthritis of the knees. They happen to also have diabetes. So diabetes is going to go second. If they say they're a long-term, whatever their medication is, whether it is in pill form or in insulin form, then we're going to use those codes accordingly based on the documentation. So that's how we start to learn how to add on additional diagnosis. So sometimes you'll see long-term use anticoagulants, long-term use oral anti-diabetic, diabetic medications, long-term use insulin, long-term use, there's different ones, right? There's a whole Z code thing about different different medications. So again, when the patient is on long-term this or long-term that, and it's directly impacting their plan of care, like the patient who will be taking like anticoagulants, that's kind of important to know because that means that the patient is at higher risk, right? Because their blood's a little bit thinner and they can't take certain things with that kind of medication. So that's also important to collect that information. But those types of diagnosis where you're selecting like the long-term use medications, you're always going to anchor those towards the end of, all of these diagnosis codes if you have to pick up multiple. Okay, we want our first four codes to be what is really relevant to the care that is going on, and then we can sequence the other diagnosis based on like severity, or based on like what how relevant it is. Is this telling more of the story, which the long-term use medication codes are telling more of the story. Okay, so those are things that you need to look at and pay attention. Don't get overwhelmed. My students, do not get overwhelmed. My new medical coders, do not get overwhelmed. Everybody screws this up. Everybody does. There's times when I think back to the things that I used to select in the beginning, I'm like, yeah, no, okay, I can see why I would think that and why others would think that too. But this is what should be selected. And when you're in school and you're learning and you're thinking, oh yeah, I got this, and there's all these codes here, I'm gonna pick up all these codes, and then you get your report back and you're like, oh shoot, I should have picked those up. That's when you start to learn, like, okay, I only pick up what is necessary for this visit, what is impacting the plan of care for this visit, and if there are additional details that can be collected that would help. If a patient came in, osteoarthritis of the knees again, but they have a family history of cardiovascular disease, is that relevant? Well, again, depending on what's going on in the documentation, but not likely, right? Because bones, cardiovascular disease. And yes, while vascular problems can impact the bone, we need to see how did the provider document. If they just put family history cardiovascular disease and then didn't say nothing else, didn't order additional workup, didn't order additional care or therapy or anything like that, is that relevant? No, it's not relevant. It's just part of the provider's documentation process, right? So we would only pick up osteoarthritis of the knees in that instance. So fun, right? Does anybody have any questions before I keep on going? So I need to check and see, since I don't know, is my laptop playing nice? Oh yes, we are playing nice. Yay. All right. Come on. All right. You be stubborn. Okay. Of course, now they turn away. Thank you for the encouragement on hitting that like button. I really do appreciate that. Thank you so much, Daniela. I appreciate that. Hi, Anna. All right. Yay! I'm so glad you're signing up. That's awesome. Like I said, it's just a one-time thing. If you want to, that's fine. I appreciate all pledges because it helps me to pay for my continuing education. I really do appreciate that because it gets very expensive. And I also get to share something that I enjoy doing, which is teaching. I really do enjoy that. That is one of the things that drives me. Is one of the best things about working, I think, is when I get to do education. So I used to do it a lot more before, but we have we have different priorities. So some of the priorities like education kind of get put on the back burner sometimes. So I would like more time, obviously, and anytime I can get education time with my providers, I am all about it. Because I think it's important, you know. Of course, Anna. I like explaining, and it's good to kind of talk about this sometimes. And I figure, what better time to explain it than when y'all are on with me? Sometimes these sessions don't. There's not a lot of engagement, so I'll kind of explain a lot of things. But if somebody wants to ask a question about diagnosis sequencing, you can. I'm here right now. You're welcome. Um, all I have to say is y'all get the self study syllabus. It's helping me. Oh, that's so great, Anna. I'm so glad. I am so glad. That's awesome because self study syllabus took me months to put together. If y'all were with me last year around the summertime, I kept telling y'all, oh, yeah, it's going to be, I'm almost done. I'm almost done. But there's so much information that I took the time to collect it and curate everything in the order that it should be. It took forever. And then, of course, the perfectionist in me, not satisfied, wanted to make sure that it was better, wanted to make sure that all the bases were covered because there's so much information sometimes. And when you're thinking about, like, what is the best way to explain this, especially if somebody's learning independently. And that was another factor that I had to think about when I was putting the self-study syllabus together was while I had a broad uh, general one, the free one that I used to post that I don't post anymore, um, this was going to be so much more in depth because I figured if people are going to pay for it, they're going to need something that's going to be more substantial. And so that I took the time to make sure that everything was there. And, putting together all the resources and references and things like that, that takes time. And so I am very proud of it, but it's a labor of love sometimes these things, and the channel and Patreon and everything is really a labor of love, and I enjoy it. So I hope other people enjoy it too. So thank you for the feedback on that one. I think I'm going to be signing up for Penn Foster uh, medical coding professional career diploma. Do you recommend it? So I never make it a habit of recommending something that I haven't personally been through. I have reviewed the website for all of the things that Penn Foster does offer. I did give my feedback on that for based on for what the website was saying. Had I gone through the program? No, but I also made that very clear. There was people that gave their feedback, actual Penn Foster students, some good feedback, some bad feedback. So especially when it comes to online learning, it's very important to know online learning is not analog learning. So if you are if you're a millennial, if you're Gen X, we understand. If you're a baby boomer, you understand how analog learning works with books. People in these newer generations, especially Gen Zs, it's and Gen Alphas, it's getting harder for them to learn because they're learning often online and everything's on an iPad. Oh, it's great for the environment. No, it's not actually great for the environment because if people don't know, if they're not getting educated properly, if they don't know how to learn from a book, it is going to affect their ability to learn. And it is going to affect the whole planet because if people don't understand its importance, like people who learn from books, there's going to be a huge difference in the future, right? So the thing about when you choose to do online learning through Penn Foster or MedCerts or wherever your journey leads you, understand that you have a personal responsibility to look up whatever it is that you don't understand because sometimes these modules will not let you advance. So if you think about like seeing another chapter or whatever because you're kind of stuck on this chapter and you want to put a pin in it and go forward, it won't let you. So it's up to you to learn how to get those coping mechanisms to say, okay, if I don't understand this, I got to go to the public library and go check out a book. I got to go find a tutor. There's a ton of tutors for medical billing and coding. Some of them are fantastic. I'm sure the only one I can recommend is myself because I'm the one who knows what I do in a tutoring session. I do tutoring, I do professional coaching, I do all that. All that is in the description box below. You can find out more information. But everybody has different needs. And so you want to find a tutor that is right for you. It's like finding an ideal work candidate. You know, you want to choose your options very wisely, and you want to make sure that it's somebody that really enjoys teaching, or enjoys coding. Because sometimes people will say, oh yeah, I'm a really good coder. Why you would say that? And then they're just like, they're stuck on certain things. Everybody should admit there are things that they don't know. You know, there are things that are not familiar to them. But it is all a matter of them also teaching you how to do your research as well, and then explaining things in a way that can help you to understand, because everybody learns differently. So you have to think about that when you're accepting something like Penn Foster. I've recommended before that if you're going to do online learning from one of these fast-paced places or whatever, don't go with 4 months or 6 months. It's too short. 2 months is ridiculous. Okay, you need a program that's going to be 9 months, 12 months, or 18 months. Okay, great. If Penn Foster is 9 months, 12 months, or 18 months, because it's self-paced or whatever, who is going to be teaching you? Are you going to have access to an instructor? If not, okay, then your next stop, if you absolutely have to take Penn Foster, then you need to go find yourself a private tutor, somebody who you can check in with and say, I have this issue, because of this chapter or whatever. I just need help with it. Okay, everybody does their tutoring things differently. Some tutors will make you pay for like a bunch of sessions up front. I do one session at a time. Okay, so you book 1 hour with me or 2 hours with me, whatever you want to. There is no discount, because I've had that too. Oh, if I buy a bunch of sessions from you, can I get a discount? Absolutely not. Because first of all, the reason that I don't do it like that, I don't allow for like multiple sessions to be booked, is because sometimes people will forget, and then I have to sit here and like be on top of you, and then like with reminding you about your appointment. We're all adults. I don't need to remind you of your appointment. I send you your Zoom link so that we have our appointment. It is your responsibility to show up. If you don't, there's a $25 rebooking charge. Should have showed up. I understand things happen, and I do have some exceptions that I do make when that happens to people, and that's okay. But I also value communication. If you're communicating with me, we're great. If not, if you just fall off and then, oh yeah, Blue, I'm back, like 5 days later after the fact, come on, man. No, we're not doing that. So that's why I keep my schedule that way. My schedule does fill up, and so it's just a part of it, because the channel is growing, and I have established clients already who have long-term bookings with me. So, I mean, it is all basically when I'm available. So I do have availability this month. So if you are needing somebody, just let me know. And you want to book with me, just let me know. But yes, so that would be what I would recommend. But I cannot tell you that yes, I recommend Penn Foster. I cannot do that because I haven't personally been through it. Now I did have a shady shyster say, "Oh well, we can pay you for your endorsement." You don't know me. You don't know me, bro. I do not. You can't buy me. Okay. I do not recommend something if I have not personally been through it. And that guy couldn't even tell me or describe to me like what was in his program, or what all it covered. He didn't even know. And I'm like, no. Mm-mm. He's like, oh, I'm looking forward to working with you. I don't think so, bro. I don't think so. That would be the one that I would say, no, absolutely not. You're not going to sit here and tell me what I can and can't say on my channel, number one. Number two, you're not going to sit here and say, oh, well, she recommend. No, absolutely not. And if I haven't been through it, that's doing y'all a disservice. And especially if it's a terrible program, which, really? I'm just saying, you know. Um, Not gonna lie, it was intimidating at first, but you have to go step by step. And my brain wants to do it all now. Oh, yes. Yes. When you do the building blocks, when you learn the medical terminology, when you learn the anatomy, all these things are building blocks, and everything builds on everything else. Okay, everything else before it. You would never just jump into the coding and then, oh, yeah, we're going to work on medical terminology. That's stupid. And there's some programs out there that are like that because they want to get the people excited first. But how are you supposed to be excited about something when you don't really understand the terminology? You got to get that terminology down first, okay? Or at least get a good grasp of it, so that way the rest of it can make sense. Just saying. Um, girl, but I was reading the whole thing and I was like, ah, I know, I get it. I get it. Um, is it possible to do it on your own if you are struggling financially? What? What are you talking about? Penn Foster? Or are you talking about my syllabus? Because my syllabus is a one-time charge, and trust me, it's nothing. It's not a Penn Foster. It's not even Penn Foster. Not even Penn Foster's what they charge. Because some people will take loans, which you should never ever do. Never take a loan to learn medical billing and coding. You know, I hear people taking $10,000 loans. It shouldn't be $10,000. It should not. Without a tutor. The tutor is a luxury. I will say that. The tutor is a luxury. You can learn it on your own, but what I'm saying is that if you get stuck, that is an option for you, and especially if you are learning on your own. If you're trying to go through Penn Foster because maybe you are part of a program and they say, okay, we have Penn Foster, we have MedSurge, we have like all these other places that you could pick from, and that's what we're going to pay for. And then you say, okay, well, I'm going to pick Penn Foster because for whatever reason you're on Penn Foster. Okay, you go with Penn Foster. Then you're learning on your own. If you get stuck, who are you going to go to? And so that's what I'm saying. There's different tutors who charge different rates. Some are cheaper than others. You know, some they're on the higher end, and some they're on a little bit of a lower end because they understand and things like that. I started off, I think I used to charge like $25. But because I was new and I didn't really know the process, now I charge more than that. But usually when you charge less like that, you get people who think that they can be mean with you. And oh no, we're not doing that, especially when I'm helping you, you know. So that's the thing, it all depends too. So like I said, there's different rates for different people. You can also, try to like figure out like what is going on. There's tons and tons of resources out there, tons of articles you can read as well. So, Penn Foster is the only thing I can afford, and I really want to get started soon. I think I would be good at it, and I'm excited to learn. That's all you need then. That's all you need. That is all you need. If you are excited and you say Penn Foster is all you can afford, that is all you want to do, no one can stop you but you. Okay? But again, you asked me if I recommend it. I'm telling you that I can't. You asked me if you could do this without a tutor. Yes, you can. I'm just saying that a tutor is just a luxury that you can use to help you to understand, to supplement your learning. Because sometimes the stuff is not going to make sense. I've seen people get so excited about getting started in learning medical. I hate lawnmowers. That's what I call cars that they try to act like they're sports cars. I drive a sports car. I know what sports cars are supposed to sound like, and they don't sound like that. I'm just saying. So, with that said, when you are, on this journey, I'm telling you right now that you're excited right now. It is exciting, but there's gonna come a time when you're gonna get stuck. So be prepared. And if you get stuck and you can work your way through it, you're all the more better for it. But I'm telling you right now, some people get stuck even on medical terminology. So always look for extra additional resources. If Penn Foster has something for HIPAA, right? And you don't quite understand what they're saying, and then if you know to Google HIPAA and then whatever it is that you're getting stuck on, and then you find an article that can explain it better to you, that's all the more better for you. Okay, so hopefully that got, that gets you right. I see the laughing faces, but it's true. It's true. I love cars and I love muscle cars, but I do not like cars that are more sound than anything else. There's no muscle in that car. None. And it sounds like freaking wind up toy. You know what I mean? And I'm just, oh, get out of here. You know what I mean? No, because a car can be beautiful on the outside, but if it doesn't have an engine, and I can tell because I can hear it, and you can feel it, especially when you're next to the car if the car has an engine in it, like actual muscle car. You could feel an actual muscle car. You could feel that engine, and that is just it's disgusting. Just saying, it's just a little noisemaker or whatever. I was really good at anatomy and physiology, so I hope I still have that quality. Trust me, it comes right back to you. It will come right back to you. But being strong in anatomy and physiology is great. Okay, um, and that will help you. It will go a long way. It's not going to carry you, because it's only part of it. It's only part of the puzzle. Okay, so when you get into the coding, it's really when the rubber's going to meet the road. You know, that's when you're really going to find out. But yes, it is possible to learn without one. So whatever you want to do. You know? So hopefully this has answered any questions about diagnosis, coding, selections, because like I said, there's many things to review, but two other things: mother baby, pregnancy coding. If you are not strong in pregnancy coding, it's going to show quick. So you need to understand that there's always going to be an O code that is listed first. And sometimes it'll prompt you to code for the additional condition or whatever. But you never code a condition without a corresponding O code first, okay? So if there's a specific pregnancy complication, and then it asks you to, code for the additional problem, then you would code for the additional problem. So O code first, and then additional problem. If it is an injury, right? Oftentimes it'll say, the obstetric code with an injury, and then you identify the injury. So that's okay. So it's going to be an S code with whatever situation, that's up in character A, D, or S. Initial, subsequent, or sequela. So you're going to code it based on that. And then, you're going to go on. Weeks of gestation, okay? That's also very important. And that's going to be anchored towards the bottom of the codes. So just always make sure that you've got that part down. When you are applying for jobs, that may be one of those trick questions that they're going to ask you, because why is obstetrics important? Obstetrics is important, of course, in OBGYN, but it's also important if you're coding for the ER, right? Because pregnant mamas will go show up there, and sometimes in smaller facilities, there's not always an OBGYN clinic open all the time, so they're seen right there in the ER. You have to know how to code for those things. So always knowing what O code goes first, or understanding that O codes always go first. Some codes are going to require a second or third code because, just to tell more of the story, you have to understand those rules. So make sure that you check on those obstetric guidelines. Orthopedics. Injuries versus musculoskeletal conditions. Injuries. When you have a patient who is injured, sometimes the injury doesn't always show up because there's lots of swelling, there's lots of trauma. So because of this, you want to make sure that if they say they're coming in with pain, right? They're coming in with elbow pain, okay? Patient presents, chief complaint, elbow pain due to a fall, all right? Patient fell, hit their elbow, okay? We don't know if there's a fracture or if they just pulled it. We don't know what happened, okay? And the provider says they did their x-rays and they said, that they can't really see anything right now because of all the swelling and things, but the patient has an injury of the left elbow. What are you going to pick up? And if you tell me pain, why? Because the provider specifically said that the patient had an injured elbow. We can code for unspecified injury of a particular body part, especially when the provider has said this patient was injured. We just don't know right now what it could be. Possible sprain, possible fracture. We don't know. But he did say for sure that it is an injury. So we can go injury, elbow, left, AD or S, depending, And so that's when we would pick up something like that. So it is okay to use those unspecified codes when it comes to injuries because injuries are not always going to show up. Sometimes it's just a sprain. Sometimes it's a fracture. It depends. And especially when it comes to children, they'll say things like occult fracture because they don't really know if it is a fracture or not. And so that's one of those things that they do because, children, their bones are still growing. So sometimes those things are kind of hard to see. So those are the things that you need to really look at, understand words like occult and what that means. And then recognize when there's things what they say like possible, suspected, likely, maybe, consistent with in the outpatient setting. We do not code for those. We code for what we know is to be definitive. Okay. So if they say it is a suspected sprain, we could still go with, or let's say a suspected fracture, right? So then we can still go with unspecified injury of whatever body part because it's still an injury, but we just don't know because they're saying they suspected fracture, but they're still injured. As long as the documentation says this is due to an injury, we've got it. Okay, so recognize and familiarize yourself with those terms. Get with your books and understand that there's going to be some injuries that are trauma related. Something happened to the patient, they were impacted, and some are going to be organic, like those pathological fractures, right? Those are going to be your M codes, which means that it's musculoskeletal. That's not people who have like osteoporosis and they break their bones very easily because like they could just, put their hand down with some light force and then all of a sudden they've got fractured bones because their bones are that fragile. And so those are things that, you're going to have to learn the difference of when to code for uh, uh, trauma and when to code for that M code. Okay, so those are things that you have to understand when it comes to coding, but they take time to learn one thing at a time. But those are some things to kind of watch out for because especially when you're getting interviewed, that would be one of the number one questions that I would ask is, can you explain to me what initial, subsequent, and sequela is? And if you stare at me during the headlights, this is not the person I'm calling back. Can you answer the question, what does HIPAA stand for? And if you come up with some malarkey, hospital information, get out of here. We all have to know what HIPAA stands for and what it is about. Just saying. Any last advice for coding op reports? 3 important facts, please, or 3 import facts. I think you mean important facts. When it comes to op reports. So, op reports, very good question. Sometimes the provider will put what the diagnosis is, right? The pre-op diagnosis, the final diagnosis, right? The final diagnosis is going to be like what they actually saw when they got in there, right? So sometimes it's going to be more specific, okay? So we want to really pay attention to that. That's number 1. Number 2, do not just take the name of the procedure that the provider puts on there, procedure performed, let's just say laparoscopic appendectomy, right? So you think, woo, I got appendicitis here. I got a laparoscopic appendectomy. I could be in, I could be out. And you only coded from, I get excited, that's why, you only coded from the title of the procedure where it said laparoscopic appendectomy, and you were like, what? I got my surgery done, and I'm on to the next. Wrong. Why? Because you get to that first paragraph. First paragraph talks about, we put the patient under anesthesia, they did their thing, we did the timeout, all that good stuff is there. Now we're getting into that meat of the potato, and that's the second paragraph. And then in the second paragraph, guess what happened? Patient, we did the incision, put the trocars in, and we started the laparoscopic appendectomy. However, we had to we had to abort that. We had to open the patient up. We had to do an open laparoscopic appendectomy. We had to do an open laparoscopic. We had to do an open appendectomy. So we converted from a laparoscopic appendectomy to an open appendectomy. Guess what? You just got the procedure code wrong because why? You were so happy to see laparoscopic appendectomy, and that provider did not change the procedure name because they're using a template. They said it in the documentation itself. So that's when you're supposed to. Okay, they did a open appendectomy. It was converted to open. So then that's when you select the appropriate CPT code for an open appendectomy, and then you code the diagnosis corresponding diagnosis appropriately. That is very important because again, all of the support for the codes that you are selecting come from the meat of the potato. They come from the document itself. And if you are blindly just picking off the procedure name and then the title of the procedure and then going on your merry way and you did not consult that meat of the potato in the op note, don't you think that the insurance is going to be looking for a reason to deny this claim? If I was that claim reviewer, I would happily say denied, improper coding, not the inappropriate CPT code. And there's a difference in that payment. Now we have a bigger problem because we either paid you too much or we didn't pay you enough. Now you're going to get a penalty if we didn't pay you enough. Oh, it's okay, just keep the cheaper one. Coding, undercoding or overcoding is still wrong. You have to be correct. Now, yes, mistakes happen. I get it. But not a blatant mistake like this. That was a lazy mistake. That was a stupid mistake. And I've seen coders do that too many times because they're rushing. They're trying to hurry up. We are also held to ethical standards, and that will always be because you see that all over the AHIMA website. It's always going to be quality over quantity. Always. And that is the third tip. That is the third takeaway. You do not rush. You have a quota. You have to do 3 surgeries, 4 surgeries per hour. And one surgery is going to take you a little bit longer. Say you did only 1 surgery and you have a quota of 4 surgeries per day, per hour, and you only did 1. That's not going to be your whole day. There's going to be some surgeries where you're going to code faster. Maybe it's a colonoscopy. And okay, in and out. It's a liver biopsy. Okay, in and out. We got this. And those you can get through pretty quickly because after a while you start to know the codes, you start to recognize what you got to do and that kind of thing. But in those instances where you have to slow down and you only do 1 and it takes you like an hour because it was really complex and there's a lot going on, a lot of moving parts, a lot to read, a lot to go over, it's okay to take your time on those. You do not rush because I will tell you that whenever you submit this code is going to go directly to the insurance company. That patient already got an estimate. They paid their copay. Now, whatever it comes out to, whatever the insurance pays and whatever the patient balance is what the patient is going to be burdened with. Make sure that is correct. Because if it is incorrect, and there's so many patients out there who probably have incorrect bills because somebody was rushing, because they were feeling the burden of the rush. Oh, you got to hurry up, you got to hurry up. You do not rush me. This has to be right. I can make up the time later, but I have to get this done right. And if your manager understands, if you explain this to your manager and you can't be pulling this card every single time, you'll be okay. Because I've seen people who say, I can't keep up with my productivity, and they're right there with their phone in their face. That's a joke. I'm going to be straight with you. You're rude. That's not rude. I'm protecting those patients. I'm protecting that provider. And I would never put them at risk. I take my job seriously, as should you. Because as we are constantly threatened with AI, which AI is dumb. It can't critically think. I don't know why people panic that, oh, it's going to take us away. No, it isn't. You see the dumb things that it collects. It collects everything because it doesn't have the ability to rationalize and think about, like, okay, what's actually going on here, but we do. We do. And so that's why I want y'all to understand studying is so important. When I tell y'all need to read, y'all need to do this, I'm not doing it just to be mean. I'm not doing it just to make it harder on you. I'm doing it so that you better understand. You can better understand what you're looking at. And then it's going to be more fun for you because there's nothing more better than that. There's nothing better than getting into that record, that surgery note, and seeing, like, okay, well, the doctor said that they did this procedure, and then you look through the note, you say, wait a second, there's also another procedure being done. You just found a gem. You found a gem without even trying because you read the note. The doctor's not always going to know what procedure code to select. They're not always going to know. And sometimes they go to these conferences where they listen to somebody else and you're like, no, why? Because they gave them wrong information. Maybe unintentionally, maybe it was only partial, but they gave them wrong information. So it's up to you to read. It's up to you to ask questions to understand. So that's my three things. Is that you pick the most specific diagnosis, that you do not code from the procedure title, and that you read the body of the note, because that could be the difference between you selecting the correct procedure code and you selecting the wrong procedure code. And then you also make sure, that's the third one right there. I know I said 4 fingers up, but the third one right there is that you do not concern yourself with productivity. You take your time. Now, don't take your time for all of them. Don't abuse it. But when there's a situation like that, you got to pay attention. And then you make sure that you code it right. Because it's better to be right and take your time than to get it wrong. I've had this discussion before with my supervisor. Blue, what happened? Let me tell you this. Here's this. Oh, okay. I worked for a level 1 trauma hospital at home a few years ago. It was a remote job. And level 1 trauma hospital, you see everything. Hunting accidents, car accidents, all kinds of things. And so I had 35 diagnosis, multiple procedures. It took me the whole time. So I went and I told my supervisor about it. And she's like, oh my gosh. She's like, this was a lot. I said, yeah, because there's all these things that are going on. She said, okay. So she gave me downtime to compensate for that extended labor for that one record, because that was it. It was so out of control, all the things that were happening to that patient because of the multi-traumas. And so they would get one situation, okay, and then another situation would pop up. So there was a lot of things going on. But if I had to rush through that, there could have been a lot of things that are missing, and that does such a disservice to the patient and to the provider. I'm just saying. Thank you. We watch you in my coding class in Ohio. Oh, thank you. Hopefully this helped. I will be leaving this live up. So if you want to come back to it, you totally can. Diagnosis, coding selection, FAQ. So that way you can refer back to it when you need to. You're welcome. As a certified coder, should I buy liability insurance on myself, like when nurses get their own malpractice policy? Oh, I really hate this question because this is cyclical, right? Where they start advertising about this liability insurance. I'll be honest, I don't have an answer. I will be honest, I do not have an answer for that. I have read many things. I have heard it on both sides. I have heard the pros for it, the cons for it. I don't know how to answer this question. I don't know how to answer the question. So I don't have an answer for you. I'm sorry, Daniela. I hate to say that, but like I said, sometimes I see advertisements for it and then they go away. And then some people say that that's it's there's a lot of things that are said about it. So I honestly don't have an opinion either way. So it doesn't help, I know. But if you're new, don't get into all those things. You don't have to buy everything that's put in front of you, okay? And even if you have experience, you don't have to buy everything that's put in front of you. You know, a lot of people get caught up in that trap too. So I just don't. I don't. I don't have an opinion either way on it. It's just like when people ask me about the micro credentials for Mahima. I don't have an opinion on that one either way. I'm with Mahima, and I don't have an opinion on that one either way. Okay, you're welcome. Thank you. Okay, I guess that would be for my employer. Yes, ask them. Ask them. Hey, Blue, keep giving us these great videos. Oh, thank you. Thanks, Blue. You do help. Okay. I'm so sorry. I always feel bad because, like, I don't know. There's just some things that, at some point you have to say whether you have an opinion on them or not. And that's one I just always kind of get stuck on. You know, I don't know. So, anyway, but I have talked y'all's ear off for an hour. Yeah, I've been on here for a little over an hour. But I missed y'all. I was gone for a week, and so it just felt weird. I mean, I film shows for every week. So every week there's something on, and last week I couldn't. So, but I'm here now. I'm all better. So I'm here. I'm with all of you, and I hope that you will continue to watch my videos. Check out what I have. Tomorrow, what am I talking about tomorrow? What am I talking about tomorrow? Give me a minute. I just haven't done the I haven't done the thumbnail for it. Gosh, I don't even have a title on it. What was it about? I don't remember. It was a good one though. It was a good one, but I don't remember what it was about. So, yes, I need to rest too, and learn from me. Okay, if you are not resting, it will catch up to you. If you're not taking care of yourself, it will catch up to you. If you are not taking the time to have downtime, it will catch up to you. Always pick healthy things like staying hydrated, okay? Um, you just got to take care of yourself. You got to take care of your body. That's it's just very important. And you know, find things that you can find humorous. Laughter is always really good. Sometimes I'm sitting there and I'm guilty of it too. I'll be scrolling on Instagram. I do the Instagram. I don't do the TikTok, okay? But I do the Instagram. And my latest one that I was hysterically laughing at was the PetSmart guy. The one he said, "Is it PetSmart? Or are you saying that pets are smart? Are you saying it's a mart for pets? Or is it, so that's hysterical." And I follow like some very funny content creators. Viva La Vargas is one that I follow. He's freaking hysterical. Sergeant Knucklehead is another one. He's hysterical too. But they talk about different things and just guy humor, which I think is funny sometimes funny. Um, but there's like a lot of really good content creators out there and with funny things. Madison Humphrey, she's another one that I follow on Instagram. Hysterical, like her characters that she does. Bistro Huddy is another one that I follow. Drew, gosh, what is his last name? Drew something, but he does the Bistro Huddy ones, little clips about Bistro Huddy. So it's funny. So find your find your happy place, whether it is online or reading a book or being outside in the sunshine. Getting yourself some sunshine time, some fresh air is always great. You always want to do that. Get adequate sleep. That is something that I am actively working on myself. So Sleep is very important for the recovery process, for improving your memory. It is very important. So always make sure you stay up on that. I'm just saying. So with that said, I'm gonna go ahead and wrap this one up because I already know it hit 10 o'clock on the East Coast. So oh, time change. It snuck up on me, but here we are. So anyway, but I'm going to go ahead and wrap this one up. Thank you guys so much for joining me. Please take the time to check out my other videos, comment, like, subscribe, share, do all those good things that help me and get my videos pushed out in the algorithm. I really appreciate it. All right, guys, have a great week, and I'll see y'all next time. Bye.